I believe we are all here, but we have some cameras that are not on already. There they are. Only Professor Katouche has his camera off. There he is. You may proceed, Mr. Prorector. We are complete.
Thank you very much. Hereby, I open this academic ceremony in which Marco Moscarelli will defend the academic thesis, Advancements in Minimally Invasive Cardiac Surgery. May I invite you to present a summary of your study and the conclusions of your thesis.
Good morning. I hope you can see.
Yes, we can.
Can you hear me properly?
Yes.
Okay. Distinguished Prorector, distinguished member of the Corona, distinguished colleagues and friends, thanks very much for having me here this morning and giving me the opportunity to defend my thesis named Advancement in Minimally Invasive Cardiac Surgery. In fact, in the next 15 minutes, I shall discuss the research I've done in the last period of my academic career. A touch of introduction. As we know, minimally invasive cardiac surgery, also named minimally access cardiac surgery, is a surgical technique that gain access to the heart through a small incision, generally an intercostal space incision. And I would say different conditions can be treated with this minimal invasive approach, such as mitral valve, aortic valve disease, aortic vessel disease, like ascending aorta aneurysms, but also coronary artery bypass grafting. However, the vast majority of my research, which is actually made the thesis of, is regarding the minimal invasive mitral valve surgery, particularly minimal invasive mitral valve repair. Some surgeons advocate full sternotomy, some other minimal invasive as the optimal way to operate on the heart. I mean, both of the two techniques have pros and cons. For example, we know that minimal invasive is associated to superior cosmesis or to reduce post-operative length of stay or blood product usage. However, the minimal invasive detractor claims that with this technique, not all the patient can be treated, for example, the high-risk patient, and not all the valve conditions can be treated, for example, complex mitral valve repair, such as a Barlow valve disease. Interestingly enough, there are no randomized controlled trials that compare minimal invasive to full sternotomy. Thus, the aims of this thesis were to assess the performance of minimally invasive mitral valve surgeon in the context of high-risk scenario, intending as high-risk both patient and valve, to explore, to promote advancement in both surgical and anesthesiological fields in the context of minimally invasive mitral valve repair. And given the lack of prospective randomized trial to perform evidence-based synthesis to compare minimally invasive and sternotomy, and last but not the least, to investigate the effect of minimally invasive on quality of life and its influence on gender. Back in 2015, we performed the first external validation of the Euroscore-2 on the minimal invasive mitral valve surgery context. The Euroscore-2 is a common statistical tool used to predict mortality after surgery. And by analyzing data of over 600 patients, we assessed the accuracy of the Euroscore-2 by the aims of the area under the curve. And here, after the curve was good for the Euroscore-2, was suboptimal for the previous version of the Euroscore-2, that was the logistic Euroscore-2. Notably, the Euroscore-2 over-predicted the mortality, particularly for the outlier, for the high-risk patients. And interestingly, the human factor, the surgeon performance, did not affect the Euroscore discrimination. Moving forward, as I stated since the introduction, the rule of minimal invasive in the context of high-risk patients needed further evaluation. In fact, we performed the first pairwise meta-analysis to compare minimal invasive and sternotomy in this kind of subgroup of patients. And after scrutinizing the literature, we included 7 studies that fulfill these criteria. As you can see for the forest plot A, primary outcome was early mortality. The odds ratio between minimal invasive and sternotomy did not differ, and the results were confirmed in the high-quality study. We concluded that the minimal invasive in the high-risk patient was as safe as sternotomy. However, it was associated to prolonged operative time. Given the lack of prospective randomized trial, the risk of bias was assessed as high. Having actually demonstrated the minimal invasive was associated to prolong cardiopulmonary bypass time, we conducted a prospective randomized trial to assess the potential cardioprotective effect of sevoflurane during the minimal invasive mitral valve repair. And we carried out a trial, and we randomized 65 patients to sevoflurane, to continuous infusion to sevoflurane during surgery connected to a heart-lung machine. And there were 35 patients randomized to sevoflurane and 32 to propofol. The primary outcome was cardiac troponin release over the 72 hours post-operatively. The result of the trial, generally speaking, were neutral. They were no different in terms of the primary outcome troponin release over the 72-hour post-operative, and even the secondary outcome, such as lactate, pH, and renal function after surgery were neutral, no different. The myocardial injury was only associated to the duration of the cardioplegic arrest. Complex mitral valve disease can be complex, actually mitral valve repair can be difficult to perform by a minimal invasive approach. And we propose a stepwise simplified technique to facilitate the repair in such a context. And the technique was basically consisted in relocating a prolapsing segment to the base of a non-prolapsing segment and to perform a sliding and ring implantation. We performed this technique in 140 patients, and at a median follow-up at 50 months, the recurrence of at least moderate MR was excellent. And interestingly, by the time the cardiopulmonary, by gaining basically expertise, the cardiopulmonary bypass time significantly reduced over time. And moving forward, as I said, since introduction, the rule of minimal invasive in the context of complex mitral valve repair needed further investigation. We perform, in this case, a single arm, a pool meta-analysis to compare minimal invasive and sternotomy for a risk patient. Primary outcome was a recurrence of at least moderate MR or redo. Several secondary outcomes were considered. Unfortunately, we don't have time to scrutinize them all, but the effect estimates were calculated as incident rates, so taking into account the follow-up, the time, And at follow-up, as you may see from the forest plot, there was no difference in between the incident rate of recurrence MR in between the mini group and the sternotomy. We concluded that in this context of complex mitral valve repair, minimal invasive was as safe as and as performant as a sternotomy, and as previously demonstrated, however, was associated to prolonged operation time. The small study effect did not this time influence the meta-analysis. We also wanted to explore the role of minimal invasive mitral valve annuloplasty in the context of standalone secondary mitral valve regurgitation. In patients with severe mitral regurgitation, moderate to severe left ventricle dysfunction, and symptoms despite optimal medical therapy. I would say these patients represent a gray area in the literature. We review data for 54 patients. Post-operative complications were acceptable with, I would say, little complication, with no 30 days mortality. At follow-up, the survival probability was good, and also the recurrence of MR was actually good. The NIA class significantly improved from baseline to follow-up. So we concluded that the mitral valve repair in this kind of patient, symptomatic with LV dysfunction, was safe. From 2015 till 2017, we conducted a multicentric study between London, the Hammersmith Hospital, and Pasquinucci Hospital, which is the northern part of Italy, to assess the effect of minimal invasive and sternotomy on quality of life and physical activity. Quality of life was assessed with the EQ5D test, and the physical activity with a portable wrist watch. We included the 50th patient on each of the group, minimal invasive and sternotomy. And the quality of life measured by the index score, as you can see from here, and the VAS score, was actually superior in the minimal invasive group. This actually result vanished after 3 months of follow-up. With regard to the physical activity, monitoring with the accelerometer, with the portable accelerometer, the minimal invasive patient and the sternotomy patient, we notice a faster recovery in the post-operative phase for the minimal invasive group. We basically concluded that the minimal invasive patient were exposed to faster post-operative recovery and to superior quality of life during the 3 months after surgery. But after 3 months, this benefit tapered down, vanished. Moving forward, and since I think we are running out of time, this is the last study which I included in my thesis, which was recently published in the European Journal of Cardiothoracic Surgery. We know that female sex is an independent predictor for mortality and morbidity after cardiac surgery. And we wanted with this study to explore whether minimal invasive surgery for valves, surgery, including even aortic surgery, would actually confer some beneficial protection to the female sex. And we analyzed a large Italian, actually multicentric registry with over 15,000 patients. This was a propensity score matching study. All the confounders that we basically corrected the study for are shown in this picture below. And after correcting the whole core for confounder, we basically come out with a cohort of 4,261 patients. But unfortunately, the female sex was associated to excess mortality in both sternotomy and in the minimal invasive group. So basically, we concluded that in female patients, unfortunately, the minimal invasive approach did not actually confer any benefits and any protection. I think I finished my presentation a little bit early. Thank you very much for your attention, and I'll give the floor back to the distinguished prorector.
Thank you very much for your presentation. The opposition will be started and will be opened by Professor Bruno Della Rocca. He was chair of the assessment committee, and he is a professor in cardiology, clinical heart failure from this university. Professor Bruno Della Rocca.
Thank you, dear prorector. Dear candidate, first of all, I would like to start with congratulating you for this nice thesis, what you have written on a really important topic, because I think we all agree that we move towards, well, more minimal invasive. You even have in one of the proposition, you even state that the future will be catheter-based. So maybe there will be extinction of cardiac surgery, but we'll see. It's really nice work, and I would also like to include your team, your well promoters in this congratulation. I have read the thesis with great pleasure, and I have some questions for you. One is I would like to start with chapter 2 on the Euroscore. And when I look at risk prediction papers, they usually end with further studies are needed, etc. So my question to you is, what is really the value of the Euroscore, and how do you deal with risk prediction?
Distinguished opponent, thanks very much for the question. I believe that shortly the Euroscore 3 will be released. So, I mean, the Euroscore 2 now is passed. I think it was originally...
I'm sorry to interrupt you. It's not about, well, which risk score is now the best, but what does this mean?
This is actually a personal statement. I'm not actually a big fan of risk prediction, because I think, and the risk prediction, it's normally based on a post-operative mortality, which I think is a component which is not very exhaustive of quality of surgery, and probably does not take into account what is actually the patient satisfaction. With regard to score prediction mortality, I think the Euroscore 2 and the other, for example, which is the STS, which is based on spline regression, which is probably it's a little bit more well performing the Euroscore 2. But again, it's probably a basic tool for risk prediction. I'm not sure I've answered properly your question, to be honest. Can you still hear me, Professor Rocca?
Somehow at this critical moment, we have a connection problem.
Yes, it's my fault, or
it's not your, no, it's from our side, because I don't see the picture of Professor La Rocca anymore.
Yes, but okay. So I will keep commenting probably in the time being Professor Rocca reconnect. Yes. And again,
he's back. He's back.
Yes, it's back. Okay. So this is actually, I'm not sure if Professor Rocca actually heard my comments on Euroscore. No, okay. Fantastic.
I'm really sorry, because I lost connection. I don't know why.
Yes, yes. I mean, what I was saying, that's the Euroscore taking into account the post-operative mortality, 30-day mortality. With mortality, probably it's not actually a proper indicator of quality of surgery. And well, this, for example, this so-called paradox of zero mortality. Centers that have zero mortality, probably they don't actually perform well. And again, taking into account just mortality probably does not reflect the proper quality of life, quality of surgery, and generally quality for in surgery. Personally, I'm not a big fan of any of these algorithms for risk prediction. I would prefer the STS, because from a statistical point of view, it's based on spline, while the Euroscore 2 is based on simply logistic regression.
Sorry to interrupt, but what is the clinical consequence of that? Because, well, I know risk, but what is the influence on decision making? And maybe also that you could speculate, well, how could we improve that?
Yes, for I mean, decision making, I think the Euroscore, I mean, the discrimination is for decision making is very weak, to be honest. Has got a limitation. It was probably acceptable in 2015, but I don't think it's utterly completely acceptable in 2020 and 2023. I mean, risk prediction, it's a little bit limited from like a statistical point of view. Nowadays, we have like a proper heart team that, see the patient in in a holistic way and make more, I would say, human decision rather than decision based on a statistical and algorithm tool. So I would say nowadays evaluating a patient is far beyond relying on algorithm, and it needs more comprehensive, more patient-oriented approach.
Do we have something like that that could be, well, because it's good to have something more objective instead of just a gut feeling. Of course, I mean, we all are doctors and we deal with gut feelings, but obviously it would be helpful to have something more objective. What do you think is required to achieve that?
Thanks very much for the question. It's an excellent question. Probably it's one of the most difficult questions that a clinician, a surgeon, can we get when evaluate a patient. I mean, we normally say, I bullseye a patient. I mean, in fact, evaluating a patient for surgery nowadays, when we face like elderly and we have to decide if this patient is suitable for catheter-based or for surgery, or even just for like medical therapy, which is now, is an option even for coronary artery disease. It's quite complicated, and it needs a multidisciplinary approach made of cardiologists, physician, cardiothoracic surgeon, a proper team with experienced actually surgeon, and that to evaluate the patient. Obviously, we need to take into account algorithm for risk prediction, such as the Euroscore and STS. In fact, as I said, and in the thesis, we even try to define frailty, because we perform this study with portable accelerometers to understand the influence of frailty, of mobility on postoperative outcome. I mean, it's a very complex topic. It's a very difficult decision. But in fact, just to answer and get to the points, the Euroscore 2 and the other algorithm for risk prediction, they are just like a part of the process for evaluating the patient for surgery. I think we lost Professor La Rocca again. Hello?
I think so. Yes, we did.
Okay.
But I think we will continue with the opposition, and
Yes.
he will join us once he's reconnected. And maybe at the end, if there is time, he will come back to you. So thank you. Thank you for your answer. And the opposition will be now continued by Professor Jacobs. He is Professor of Vascular Surgery of this university and also member of the assessment committee. Professor Jacobs.
Thank you, Mr. Prorector, dear candidate. Congratulations. I'm actually in the same building as Professor Bruno La Rocca, so I should be like 75 meters away from him and see what the digital connection is doing to us. So, once again, congratulations in this very successful Dutch-Italian connection, which is delivering many scientific works and PhDs outcomes here. So also congratulations to the chief of the Italian connection, Professor Lorusso in our team. I have two questions, so I would like to address the first one, which focuses on chapter 3. The title is what the role of minimal invasive mitral valve surgery in high-risk patients would be. It's a meta-analysis. And then you have two groups. One group is treated by means of a conventional standard sternotomy, and the other one, obviously, by means of minimal invasive techniques. And your conclusion at the end of the publication is that minimal invasive mitral valve surgery is safe and comparable alternative to sternotomy. So, well, that's great. That's interesting, because if you go to page 72, I look at your table where all the results are described, like cardiopulmonary pump time, the repair, stroke, atrial fibrillation, renal failure, etc. So when I look at all these outcomes, there are no significant differences. So your conclusion is, okay, it's comparable. But what about the aim of the procedure, which is the valve repair? What is the outcome of the valve repair in both groups? Is there a difference in paravalvular leak, insufficiency, regurgitation, etc.? I don't find that in the entire chapter. And I guess that is the end goal of the treatment. What do we do with the mitral valve and what is the outcome? Could you comment on that?
Distinguished professor, thanks very much for these questions. I performed two meta-analyses, which are both included, well, many meta-analyses, but two of my meta-analyses are included in this thesis. The first one is in chapter 3, the one we were discussing. And in this first meta-analysis, we did not take into account the actual performance in terms of mitral valve durability. That was not actually taken into account. We just took into account safety, mortality, and morbidity. Later on, we perform another meta-analysis about performance at distance of the mitral valve repair. So just to answer, going strictly to the point, in the first meta-analysis, only safety like mortality, morbidity, and post-operative complication were considered. In fact, we used odd ratio. In the second meta-analysis, which was the pooled meta-analysis, single arm, we in fact took into account performance of the repair, and we basically meta-analyzed the data with the incident rate ratio.
Okay, I understand, but can you imagine that a reader like myself is a bit surprised that the primary endpoint of such a study would be the performance of the repair, and secondary endpoints would be the risks, the infection rates, complications, and etc. So when you start reading the manuscript, you are waiting somewhere for description of the outcome of the primary goal, which is the valve repair. But okay, I understand you explained that this was not the aim of the study, but at least I would have expected some kind of description of the valve repair as such.
Yes.
Okay, thank you very much. For the second question, I would like to take you to chapter 8. Because in this chapter, you describe the effect of minimal invasive surgery and sternotomy on the physical activity and quality of life. My question focuses on the difference in both groups, because the minimal invasive group had 100% isolated valve repair, right? Either mitral or tricuspid or etc. But the medial sternotomy group had only 80% isolated valve repair, and 20% had a combined procedure, either with a coronary bypass or double valve or something like that. Okay. So the question is, if you go to all your conclusions, how does this difference in the two groups, having 20% combined procedures in the second group, influence on the outcomes, and do you consider that your conclusions are justified on the basis of two different groups?
Professor, thanks very much for this question. Unfortunately, this was a non-randomized trial, so it was an observational trial, and vast majority of isolated valve, I mean, by definition, in the center that participated to the study were performed in minimal invasive. So there was no possibility or little possibility to include isolated valve in full sternotomy. So this is a simple question. I want to be a little bit more cheeky. If you see the partner 3 trial, which is compare AVR versus TAVR, even the AVR are combined procedure. So this is the partner 3 trial. So this is, you know, an incredible bias in one of the most important trial we have nowadays, that many AVR, I mean surgical arm, the partner 3 are combined procedure, while the TAVI by definition are isolated procedure. So I mean, in terms of like valve study, the problem, the bias you are highlighting is unfortunately is very common. But mine was not a randomized trial, it was just an observational study with all the limitations that an observational study has.
Okay, great. I'm not a cardiac surgeon, but I'm surprised to see that the CPB times are significantly shorter in the medial sternotomy than in the minimal invasive group. Correct?
Well, in the minimal invasive group, generally speaking, the cardiopulmonary bypass time and cross-cut time are longer. I mean, nowadays surgeons are getting, you know, a big experience in minimal invasive. So I would say surgeon can like achieve probably same results in terms of like CBP exposure time as medium sternotomy. But generally speaking, in literature, what we have that operation time are prolonged for the mini group compared to the standard sternotomy group.
Sure. Okay. Well, thank you very much. And satisfied with your answers, I would like to give the microphone back to the prorector.
Thank you very much. The exposition will now be continued by Professor Bulletin. He is head of the cardiac surgery in the University Haifa, Israel. Professor Bulletin.
Hi, dear candidate. Thank you for a very impressive book and presentation. And congratulations your promoters as well. I will have 2 questions. I will start with the first one. What do you think, since your thesis is mainly of minimally invasive, I have a general question regarding the training of a young surgeon in minimally invasive, and maybe for your own experience, or what do you think should be the future? Because we all know that to teach mitral valve repair is already a problem for young surgeon, and to do it minimally invasive may cause more problems. So what do you think, your own experience, and for the future, if this is going to be the main way that we treat the mitral valve?
Distinguished opponent, thanks very much for the question. I would need probably a couple of days to answer this question, and which is so broad.
5 minutes.
So broad, so difficult. I think we are in a very crucial moment where we are jumping from like the cath lab to theater to the lab, and it's very difficult to train a surgeon nowadays. But even for aortic valve replacement, because nowadays the vast majority of isolated valve replacement in young, patients are done by minimal invasive approach. It's very difficult sometimes to do, even for experienced surgeon. And can you imagine to pass to teach young fellow for this procedure? The learning curve is very steep, is very difficult. You need time, you need obviously a good teacher, good actually senior in front of you, and a very dedicated program. For the aortic valve, the future will be catheter based, I'm pretty much sure. For the mitral valve repair, eventually we'll get there. Eventually, vast majority of the procedure will be done in a catheter-based fashion, but we are not there as yet, because the repair procedure is difficult. It's different from replacement procedure. So just to summarize, training is very, very difficult. You need a dedicated program. And in essence, the future will be catheter-based, as I stated in the thesis.
Yes, but for mitral valve repair, that I, at the moment, don't see good solutions, catheter-based, to the vast majority of patients. You have a trained cardiac surgeon that did all the learning curve, doing it in, as you just mentioned, minimally invasive in a relative short time, not too much pump time, not too long course claim. And you are reaching the age that you have to teach someone new. What do you think? What the needs? Is it possible after you finish the learning curve, what to do with the young surgeon, or to leave them out of the?
No. Well, yes. Dedicated program. You mean you need to start from scratch. For example, simulation. Simulators are very important. This is probably the first step. And then you go full sternotomy, for example. You master repair in combined cases, for example, with coronary artery bypass grafting. And then you can start doing like a simple repair, like isolated annuloplasty or P2 prolapse, for example. This is like a way to step by step face mitral valve repair from simple to complex situation. But again, it takes time. And you need to monitor your result. This is very important for quality purposes.
Okay, I think this may resemble one of the major problems of this surgery, that it's easy to learn, or generally possible, but to teach the younger generation without the robot, and at the moment the robots are not available too much to mitral valve surgery. I think this is the next problem. I will switch to my second question regarding what you wrote in chapter number 7 regarding the annuloplasty ring for type 2 mitral valve prolapse, regurgitation. What do you think about this option as the only treatment for mitral valve regurgitation type 3B, that we know that probably the problem is not the valve? What are the other options? Is it a good option? Which patient you will operate like this?
Yes, I mean, obviously, thanks for the question, first of all. If the left ventricle, for example, the papillary muscles are involved in the mechanisms of mitral regurgitation, you need to take this into account. You can perform papillary approximation or relocation, for example. This is very, very important because, as you stated, in this case, like a 3B Carpentier definition of mitral regurgitation, you need to act on the ventricle and on the papillary muscle as well as at the ring level. By all means, there's something more that need to be done for this kind of valve.
Okay, and what are the options by minimally invasive technique? Is it different from open surgery?
Again, it depends on how proficient are you in minimal invasive. Obviously, to relocate papillary muscle and minimal invasive is feasible and is durable, and but you need to have like experience with that. I would say many of these patients, they have like coronary artery disease, so it's a combination of coronary artery bypass grafting and mitral valve repair, because sometimes is of a ischemic etiology. So in some cases, many cases actually, you perform papillary relocation, approximation in combination with coronary artery bypass grafting.
Okay, if there is a difference between minimally invasive or open mitral valve repair, medial sternotomy, regarding this kind of patients?
Sorry to interrupt. Could you give a very brief answer, because then we could move on to the next member of the opposition?
I would say it depends on the surgeons. So this is my final question, my final answer.
Thank you very much, and for your answer, and I go back the microphone to the pro-rector. Thank you.
Thank you very much. The opposition now will be continued by Professor Bonaros. He is a professor in cardiac surgery from Medical Institute, Innsbruck, Austria.
Thank you, Mr. Prorector. Dear candidates, I think that the thesis is a significant contribution to the body of academic knowledge, and I would like to congratulate you and your promoters and the academic leadership of your institution. I would summarize the two questions. One question has to do with risk assessment. We know that you have discussed the Euroscore. There are new data which came out at the last STS and also published the ATS last month. So which shows that if we take into consideration degenerative mitral valve regurgitation, the risk of the procedure keeps very low also in high-risk patients, which goes in line with your findings. Now I would like to ask you, what do you think is the impact of age in terms of risk stratification? And I ask this question because we know we have transcatheter techniques which may reduce the risk, but may have some counterbalance on the efficacy of the procedure. My concrete question: what do you think is the impact of age, and how do you inform an old age patient?
Distinguished opponents, thanks very much for your question. I will go straight to the answer. I think age is a major component, and it might definitely and importantly affect the postoperative recovery, and generally speaking, it might affect the procedure. Obviously, biological age is probably different from a numeric age. But again, from like a statistical point of view, let's put in this way, age has to be taken into major consideration.
Is it, sorry to interrupt you, is it a concrete answer on if you have an older patient with a P2 prolapse, let's say 80 years old, How do you inform him or her?
Well, nowadays, P2 prolapse, it's very well repaired with the minimal invasive procedure. So, I mean, if the patient, is a solid patient, I would by all means go straight forward to surgery. But I mean, we do on a regular basis in this case. But it is, you mentioned a prolapse, which is very important. In fact, if it was like secondary MR, I would probably go for like a mitral clip.
Thank you. This brings me to the next question, which is about the risk of bias in meta-analysis. I think you have outlined it very well at your presentation and also the manuscript. So you performed two meta-analyses, one included in chapter 3 and another one included in chapter 6. Now, if I read your conclusions, you say that mini-invasive mitral valve surgery is a safe and comparable alternative to standard sternotomy. Now, we all know, and you've showed it on the table, that there is a risk of bias because the patients you select for the mini-invasive procedure are, for example, do not have peripheral artery disease, do not have a calcified aorta, do not have mitral valve calcifications, etc., etc. Now, I would like to emphasize the risk of stroke. Interestingly, in your meta-analysis, you found a reduced risk of stroke in mini-invasive patients. As I read it in your text, the incidence of stroke was statistically significant lower. So this does not go in line with the literature because, of course, you have the peripheral cannulation, you have all these retrograde perfusion. So do you think your finding is kind of related to the risk of bias? And how do you inform a patient coming for minimal invasive surgery in terms of the risk of stroke?
Okay. Thanks for the question. In my experience, the risk of stroke for the genital MR is very, very low. And there have been in literature very different studies that basically highlighted that underscore the safety of retrograde perfusion, of femoral perfusion. And so I would say nowadays, since the generative MR is not associated, not often to vessel disease, vessel calcification, retrograde perfusion is very safe. And again, I would say there's no major difference in terms of stroke in between minimal invasive and full sternotomy. There are some tricks that you need to do before surgery, for example, like a CT scan, and a CT scan would, would tell you how soft and how calcified is the aorta. So you need to prepare very well the patient. And so this has to be taken into account. But generally speaking, I would say there's no major difference between sternotomy and minimal invasive with regard to stroke. So I would inform the patient concerning the risk of stroke. In the same way, I would actually warn a patient due to sternotomy surgery.
Thank you. I really like the clinical implications. Hartelijk dank, mille grazie, and I would like to pass to the prorector.
Thank you very much. The opposition now will be continued by Professor Angelini. He is a professor of cardiac surgery from Bristol, UK. Professor Angelini.
Thank you, Prorector. Good morning, Marco. I'm very well aware of your work, which I admire for a long time. Mine is more of a sort of general question. First of all, I'm very pleased to say that you put in between brackets minimal access. I think there is a lot of confusion when people talk about minimal invasion. I think what we're doing here is just a small cut. And I'm glad to see that you have highlighted that something which is not very common, which brings me to the second question, which is very much related. A lot of the work then you have analyzed, whether it was yours, but mostly work done by other people, do you think is affected by a significant bias component? Because as we know, people who tend to report their results are the so-called the converted one. not the one to be converted in the long term. So that is just a general question. How do you account, if is that the right word, in your work of this possibility of bias? And just to finish, there's been a large randomized study in the UK recently concluded from Enoch Aquala from Middlesbrough, which actually show absolute no difference in anything he ever measured. But thank you again, a very, very good piece of work.
Thank you very much, Prof. Yeah, I mean, we have been working together for probably more than 10 years, you know, along with the Professor Athanasius and Khalil. So the vast majority of the research I presented, you know, were done with Prof. Angelini, Thanos, and Khalil. I will answer probably you know, the second part of the question. Probably, Prof, you were referring to the UK mini trial.
Yeah.
Okay, so this is probably just recently concluded. To be honest, I'm not aware of the full results. Yes, bias is a major problem, and as I said at the time of you know, doing all this research for my thesis, there were no randomized prospective trials. So I mean, meta-analyses were born by definition to, you know, include only a randomized trial. So whatever comes after randomized trial is a statistical trip. We are full of reporting bias. So the answer is yes. Risk of bias is a major issue. It's throughout the literature in minimal invasive, but this is our fault. It's a fault of the surgical community that we haven't, you know, been able to done a proper trial since the beginning, since the start of the, you know, the minimal invasive era. So to answer, yes, the risk of bias is there and probably is very difficult to overcome.
Thank you, and thank you, Pro-Rector, for giving me the chance to ask the question.
Thank you very much. The opposition will now be continued by Professor Fatouche. He is from the Department of Cardiac Surgery from the University of Palermo, Italy. Professor Fatouche. Somehow we have lost connections with him. Are you there, Professor Fatouche?
You hear me?
Yes, now I hear you.
Thank you, Pro-Rector. So my congratulations for Marco for this amazing presentation and for your gorgeous job in the last 10 years in research, and specifically in this issue. So my question is, do you think today there are some difference in minimally invasive approach? So I mean direct vision, full endoscopy. And do you think that robotic surgery today have some advantage over the minimally invasive approach?
Dear Prof, thanks very much for this question. It's still a broad question. I mean, yes, there's, I would say, some heterogeneity in the different approach of minimal invasive. Some surgeons advocate the axillary access as the best way, you know, to gain access to the mitral. Some other prefer a direct vision, which is probably allow you to be a touch more, I would say, faster in repairing, because you go, you know, you see directly through the hole, and so to the heart. And other prefer video assisted, and others robotic. I would say from literature there are some network meta-analysis, you know, to compare this different approach. But I would say nowadays we do not have any evidences from the literature to draw final conclusion about which of these technique is superior. Again, just to directly answer to the Prof question, it depends on team and surgeon expertise.
Okay, thank you, Marco, and thank you, Pro-Rector, for this opportunity. Yes.
Thank you. The opposition will now be continued by Professor Anastasio. He is a professor of cardiac surgery in the Imperial College in London, UK.
You're on mute.
Professor Anastasio, you are on mute.
Yeah, okay.
Great. Sorry to...
Thank you very much, Prorector, for the opportunity to participate and contribute in this nice day discussing these academic issues of minimally invasive or minimal access mitral valve surgery. First of all, I would like to, dear candidate, to congratulate you. You have done very hard work to carry out several trendy studies on your thesis for minimal access surgery, including RCT, propensity matching, risk stratification, meta-analysis, and methods that they try to eliminate bias or to introduce more bias in the whole process of identifying the evidence in the decision making. I have a little comment to make that all these studies, even the randomized control trial that Prof. Angelini mentioned earlier, which failed to demonstrate superiority or and demonstrated that the two techniques are equal, introduced bias because the complexity of the disease was not part of the matching. So I will resume a little bit the comments of Prof. Bonaros, who is really a big expert in the endoscopic approach, and he has touched the basis on the complexity of the disease. What is your view that when a Euroscore, for example, is a risk stratification tool for mortality, should we use it at all in the MDTs for complexity of to decide what is the best approach for a patient when there is nothing in the Euroscore for complexity of disease, there is only complexity of patient in the Euroscore, and the MDT, they don't have experience even what the Euroscore involves. So I would like to ask you this question. What do you think will be the ideal way forward for this?
Thanks very much, Prof. Athanasios, for this question. Yes, I'm fully in agreement with you. The Euroscore 2 does not take into account the complexity of the valve disease. So it's, I don't say it's futile, but, well, it's not futile, but, you know, it's probably not enough. As I stated since the beginning, we need a more comprehensive assessment of the patient that include also valve complexity and even surgical expertise. The Euroscore 2, again, it's just like a little part of the process of evaluation of a patient, and as unfortunately a little components in the process of evaluation, you know, risk for surgery and for the patient itself.
And another question has to do with your paper on female patients. Why do you think that the female population is problematic for minimal access mitral? I think it's a bias as well for coronaries. They say that it's smaller targets, but I have seen that the outcomes are similar, and I haven't seen any difference in my practice.
Yes, I mean, gender medicine nowadays is very, very, very popular. So there have been loads of focus on identify why female are exposed to, you know, and they carry, you know, higher risk after surgery. To be honest, to be candid, I don't have actually a proper answer to this question. Definitely, the propensity score matching. I mean, you are one of the probably most expert in propensity score matching in at least in Europe. So it's futile my answer of this question. But probably the propensity score. I mean, there are probably how many type? 10 type, 11 type of statistical propensity score to be performed, and obviously, risk of bias cannot be ruled out. With the last research included in the thesis, we basically demonstrate that female are still independent risk factor even for minimal invasive. But again, it can be a biased conclusion, as you mentioned.
Thank you very much. Thank you very much.
Okay, thank you very much, Professor Alexander, to you. Professor Della Rocca was forced to leave our meeting because of internet connections. So in the last 1 or 2 minutes, he can respond to your answer to your question, Dr. Moscarelli, and maybe have an additional question. So I give the chair back to Professor Bruno Della Rocca.
Yeah, thank you very much. I'm really sorry about that, but I just would like to keep it simple and ask a simple question. Why is it so difficult to perform RCTs in surgery?
Thank you very much for the question. There are probably many components that make an RCT difficult to be done in surgery. First of all, funding. So I would start since the beginning. And nowadays, getting funding for an RCT is a miracle. So this is probably a major step. So, but if you secure funding, you can get there. But this is probably a major problem. And secondly, with the funding, you need to maintain a trial unit. And again, it depends on money. But again, if you have like a good idea and a good research question, then you'll get there easier. So I would say originality of your research question and funding makes feasible to perform an RCT.
Okay, thank you very much for this question. I think we are done, so I'm happy with your answer. I would like to give the word back to the prorector.
I think we just heard the beadle speaking the words hora est, meaning this is the end of this part of the opposition. Marco Moscarelli, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberation and our return.
Please proceed, Professor.
Yes. Marco Moscarelli, the degree committee here present online has assessed the quality of your thesis and your defense. In the view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Lorusso is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your superiors to now take the floor.
Thank you, Mr. Prorector. So, dear candidate, actually now doctor, do you promise to work in accordance with the principle of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I do promise.
By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Marco Moscarelli, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisors, affixed with the official seal of the Maastricht University, as I think shown by the below, or yes, as you will see now.
Thank you very much.
So that's a little bit my turn, Marco, to give a few words to end this ceremony, official ceremony, and I think we all appreciated your defense. But I would like that your passion for research and additional development in surgical techniques highlight your genuine and solid commitment and creativity in this field. I must say that I again congratulate also your previous mentors, so Professor Angelini, Professor Attanasio, and Professor Fatouche, since I know very well that they have been really long time working with you, and I'm sure that a lot of your current values came from their teaching and their really support to your career. So your clinical and research activities range in a rather vast scenario, from myocardial ischemia and preconditioning to transcatheter procedure, from valve repair, replacement, and reduce to off-pump coronary surgery. So you are also a principal or co-principal investigator in many clinical trials. So you apply your focus and efforts in many fields of your professional life, but with a particular attention to science and scientific engagement. As you know, unfortunately, research is progressively neglected by the young generation, felt as unnecessary or useless for a career of a true surgeon. You are a proof that the passion for research may still exist and guide your daily professional activity. I do hope that you will strive and fight every day to make younger surgeons following your example, explaining and showing why this pathway and professional career is critical. I know not all professionals should do research, but at least should have an analytical mind, a professional and clinical curiosity about the hidden mechanisms of diseases and the still incomplete and sometimes suboptimal treatments. We must understand more, and even our small and humble contribution maybe represent a valuable provision and advancement towards improved knowledge and better patient outcomes. We should not look at our failures as unsuccesses, rather as a drive towards more engagement, for more research and dedication to find better solutions or enhance care. You also work to design and develop new surgical instruments. So you are a bright example of what I call a Renaissance surgeon. This should be the ultimate goal of a professional basing your mindset towards improved knowledge, enhanced patient treatment, and discovering maybe or developing new tools always for better patient care. We are therefore grateful to you more than what you are grateful to us today, since our service towards you will end up, of course, with this ceremony, but your promise, the promise you gave us to work and proceed in your professional career, start officially, and I would say with a oath today, even if you have been already working this way so far. So today, you kept an official personal commitment which will bond you to pursue your future action, respecting the scientific integrity, being honest, independent, and responsible in clinical and research settings. Keep Maastricht and this day as a lighthouse. Keep this recognition as a spotlight towards your activities in any setting of your work and research. People, particularly the younger colleagues, remember, will look at you. So please be and remain a reference and an example for them, while doing your best for the patients who will also look at you with hope and trust. So finally, let me congratulate you, your family, colleagues, and friends and mentors, as I said at the beginning, who will support you not in an easy task to maintain such a promise.
Thank you very much. Thank you.
Dear Dr. Moscarelli, also on behalf of the Maastricht University, I congratulate you with the degree you have acquired. And for our foreign guests, a small remark. Obtaining the doctorate degree in the Netherlands is the highest academic distinction there is. Although frequently see gray, old, and in the past men who are becoming professor as the highest degree, but actually it's not in the Netherlands, it's the doctorate. The professorship is a function. So I would truly congratulate you with obtaining this degree in line what Professor Lorusso was saying, also you, but also your family. And the Maastricht University also hopes to continue this unique North-South collaboration between our university and the Maastricht colleagues, and we hope that you will play an important role in that. And with that, I would like to end this ceremony and thank the audience for attending.